today I'm going to share sort of two things with you. We're going to start off talking a little bit about opioids and best practices in prescribing opioids when we need to do that. And I'll share a little bit about my experiences and the perspective. And then we're going to spend a little bit of time on substance use disorder. And Charlene with University Learning Systems, who I've known for a long, long time, was kind enough to let me come and introduce you all to some training that some colleagues and I have developed around substance use disorder as part of a federal training grant for SAMHSA. And in the US, the SAMHSA, the Substance Abuse and Mental Health Administration, helps to provide training and services for individuals with addictive disorders. So we're going to try something new. So y'all are hanging there with me. It won't be quite as good as Jeopardy. But I'm sort of orient you to one of the modules about treatment, but at the same time, I'll share with you some information and some links if you'd like to finish the other 3 modules within that portal. You can do that. It's free. It's covered by our federal grant, but it will also give you an additional 4 AMA or ACPE or advanced practice nursing CE credits. And so for any of you that are interested in that, we would love for you to participate that. The only thing I ask is if you'll fill out a little short evaluation when you're done, so I can send that to SAMHSA. But we'll walk through the treatment part together a little bit today. So we'll see how that goes. Well, let's start off with opioids. I've put a random selection of opioids under your chair. So I'd like for y'all to go ahead and take that now. And then in 45 minutes, we're going to figure out which one you had. No, just kidding. All right. So what we're going to talk about with opioids is we'll talk a little bit about the guidelines for chronic use. And but I've had some unique opportunities professionally. I've served on licensing and regulatory boards in a couple states now, and had the opportunity to do a little bit of work with the Federation of State Medical Boards. But serving on a medical board is an interesting experience. So I've had less experience with nursing boards, but my father chaired the pharmacy board in our home state for many, many years. So I'm familiar with those two. But we are supposed to self-govern one another as medical professionals, as nursing professionals, pharmacy professionals. And that's part of our ethical and professional commitment to our disciplines. And the government typically, although it varies state by state, as long as we do a reasonable job, will allow and sort of delegate some of the entrustment for much of that sort of professional oversight and autonomy to us as disciplines. Sometimes now when things get a little out of hand, or the politicians are really eager for a hot button issue to get reelected, they may take a little bit of that autonomy away for us or regulate us. But in general, we can sort of self-regulate. The opioid issue is one where the government has stepped in more at the state and the federal level because of the issues and not feeling like the work of the medical boards and nursing boards, pharmacy boards alone was enough. But having served on that and sort of sat on the panels for hearings for I don't know how many, lots of hearings for peers, for nurse practitioners, for PAs, for physicians, and others that have had concerns about their interaction with controlled substances. I want to share with you a little bit about how you can continue to do what you do, take great care of individuals, and at the same time do it with sort of indemnity authority or liability authority, so you stay out of trouble and you avoid the unpleasantry of being investigated or evaluated by your licensing board. Does that sound okay? Okay. And there's some simple things you can do that really do insulate you from concern. So we're going to talk about some of the evolving prescribing practices. We're going to highlight the guidelines. And actually, the CDC has a new set of guidelines coming out very soon. I saw a draft copy of it last week. So keep your eye out for that, some updated guidance around opioid use. And they've been working on it for a long, long time. The latest guideline that we have was an interprofessional team of medical and nursing professional, public health professionals, social workers, regulators, and others. And they did a fantastic job giving us some guidance about best practices for the treatment of chronic non-malignant pain. But you'll see more guidance from the CDC coming soon. And then we'll talk about some of these ways to stay out of trouble. So quick poll here. What's the most common chronic condition or the most incident condition in the U.S.? Cancer? Any cancers? No. Coronary heart disease. It's up there. That delicious pork they have at the luau can accelerate it, but it was probably worth it. How about diabetes? Or how about chronic pain? We are talking about opioids, right? So, okay, not challenging it hard like Dr. Bland with Jeopardy. But if you sort of look comparatively in the United States, like 100 million patients are coming in with complaints of chronic pain. So, from a variety of causes, but it's one of the most common things we'll see. Mental health issues and chronic pain issues are predominant in primary care. And if you kind of put that in the context of other things like heart disease and diabetes, it's really quite incident. So, we need to be prepared to how to deal with it. How many people have substantially reduced the amount of opioids they've prescribed, or if you're a prescriber in the last, let's say, 5 years? Or are you kind of hanging about the same? You never sort of did it in the first place? Yeah, let them just get the heroin off the street. Quicker onset of action. It's tricky, right? I mean, do you remember when sort of the pharmaceutical companies were promoting new products? We had fancy sustained release products, and I remember being practicing in rural family medicine, and the thought at that time around chronic non-malignant pain was, well, we need to do kind of it's almost like insulin, and it was very intuitive and logical. We need to do this like basal dose where people take a daily extended release or sustained release, and then we give them their kind of breakthrough, kind of meal like insulin, where they take then those rescue opioid. And that was it. I mean, that was sort of very intuitive, and that sort of made sense to me. And so we saw millions of prescriptions for that type of format for chronic opioids. And then only when it became sort of significantly more problematic have we sort of pulled back. And now what we find from the evidence is that method not only wasn't safe, but it also wasn't particularly effective. But it's a big shift for us. And no single group's to blame. I mean, we're learning, but it's a complicated sort of situation for sure. But we're going to focus on the opioids. You know, some get more bad rap than others. Fentanyl is the culprit in the majority of unintentional overdose and deaths. In folks that are diverting it, it's often used as a sort of even if they're not describing fentanyl in the product, they'll often sort of adulterate the product with fentanyl. So relatively cheap to produce and so forth. But when we think about addiction or substance use disorders, remember addiction's a primary and it's a chronic brain disease, so chronic relapsing disease. And it can happen after very limited exposure to opioids, we're actually finding. So about 2 million folks in the United States have a substance use disorder with prescription pain medications. It's the most common for sure. And co-occurring disorders are pretty common. So that means you have this issue with substance use, but you also have another psychiatric illness, depression, bipolar disorder, an anxiety disorder, schizoaffective disorder, schizophrenia. You have sort of another, and that's quite common in the US. But opioids are the single number one cause of drug-related death in the US, and it has been for 20 years. Heroin used to be a bigger cause, and then it was easier to get access to prescription opioids, so they took over. And now that prescription opioids are they've sort of tightened down the hatchet a little bit, now we're seeing increased uses of heroin again. So we'll sort of probably see those kind of fluctuate. But if you look and sort of see here, you can see that it's not surprising. The more opioids that people have, the greater likelihood that they're going to die from unintentional overdoses. And what are the mechanisms for opioids to cause death? What's the number one? Yeah, sorry, I didn't mean to get in the middle of breakfast. Yeah, respiratory depression. I was in Wilmington, anybody been to Wilmington, North Carolina? Beautiful, beautiful sort of seaside town. So I was there with the North Carolina Medical Board at that time, and we were doing some training for physicians in one of their larger health systems. And one of the investigators at the medical board that worked with us, and I went, and we all sort of went around to visit with the community. But I went into a home of, she's probably in her mid 40s, maybe 50, and she had been injured at work, had really significantly hurt her back. And Wilmington, North Carolina, surprisingly, has one of the highest rates of occupational injury in the country. It's one of the reasons we went there. So she had a daughter who was about 13 or 14, and her mother had had multiple surgeries. She had been through interventional pain treatments and was really in debilitating pain, couldn't work, sort of fully disabled. and they were under very close supervision. Were giving her opioids and other adjunctive medications to treat pain. And her daughter said that in a typical week, she had to rescue her mom with an injection of Narcan, like usually 4 to 5 times a week, because she would pass out or not be responsive. And can you imagine being in a home and you're a early teenager and this is the experience? I mean, so it's a big deal for the families that are suffering with it. And she was certainly dependent on the drug. She wasn't diverting it. She had an excruciating pain syndrome. She had been evaluated thoroughly by pain specialists, but again, her reality was pretty tough. So I always think about them in my mind. So if we look at sort of since about 2020, they're usually about 90 to 100,000 deaths in the U.S. each year, but the pandemic increased those numbers. It increased both use and likelihood of death. And we saw a 55% increase during the pandemic period. And we'll have to see whether that sustains or as some of the pressures of the COVID pandemic fade, if we'll see substance use decrease a bit. It been a stressful period for families for a lot of different reasons. But about a 13% increase in the use of illicit drugs. And one of the other things, if you're a pharmacist, you may experience, we had issues with access to buprenorphine during the pandemic, and that created a lot of complications for people on medication-assisted therapy. It was about 1 in 5 as of kind of early pandemic that we were having issues with buprenorphine access. That was tough. And then you can see a few other things here. Colorado had I know a few of y'all from Colorado had a pretty big spike in death rates during the pandemic. And we also saw a pretty big increase in individuals of Latinx background having, as well as Black Americans having issues with increased opioid related death. It's been kind of a little tough period. I remember, I was working at George Washington University of Washington until about 4 months ago when I moved to Boston, but we lost half of our psychiatric team. They just burnt out after the first year of the pandemic. We had one substance use addiction specialist left, and she was always sort of on the edge of not being able to hold it together because just the overwhelm in our ERs couldn't keep the beds were full, people were in the hallway. It's really been a rough last few years for sure. Get back to my right slide here. Sorry about that. So if you think about that group we talked about the 100 million Americans. That's about 1 in 10 that comes to see us if you're in primary care who is experiencing chronic pain. And we, if you're a primary care provider like me, are sort of responsible for about half of the opioid prescriptions in the US. So we're a big part of it. So what can we do then to make a sort of a positive impact on opioid? So the one thing we can do is we can try to prescribe less. That would be an obvious option. Another thing that we can do is try to reduce the dosages that we use to keep the levels a little bit lower to prevent the unintentional deaths that are the primary cause. And the other thing we can do is try to exhaust other options, non-opioid based sort of therapies. So let's get a little bit of geography going. Which state do you think has the highest rates of opioid involved overdose deaths per capita? I heard of West Virginia. It's always in the news, right? Ohio, okay. I do love those little peanut butter chocolate covered things they do, and I think that would be my addiction if I lived in Ohio. I mean, Florida's constantly having busts down I-95 for opioids. Californians are on something. I don't know what. What do you think? That's right. It's West Virginia. So you can look, this is based on per population, so it's adjusted. But if you're in beautiful Hawaii, although the Hawaii Islands do have issues with opioid use, 2 or 3 drugs in particular, you can see sort of some of the ranges here. I didn't include everybody, but here's where I'm living now. But West Virginia, Maryland, New Hampshire, and Ohio really lead the country in terms of, and it's a very close relationship between the number of prescriptions and the number of deaths. It's a linear relationship. So the more you prescribe, the more deaths we'll see from unintentional overdose. But every day, about 46 Americans die from an opioid overdose. So it's quite a lot. You see some different factors. So actually, younger people are the most vulnerable here. 25 to 54s, we see the vast majority of dates. They may be a little bit more cavalier with their use of it. Another group that we see are non-Hispanic whites and American Indians tend to have high rates. If you use an opioid along with any other medication that can suppress respiration, like a benzodiazepine, you see a significantly increased rate of death. And we also see a little bit higher rate among men than we do women. Like in my daily household situation with 3 daughters, a wife, and a female dog, clearly women are smarter than men. I get that reinforced on a daily basis. And it widely varies. So prescribing patterns, typical doses are just very regionally disparate. And if you see areas where there's a lot of workforce injuries or workplace-based injuries, you'll typically see higher prescriptions. There are some pockets where the legislation has not been as stringent and you'll see a little bit higher prescribing. So you have to kind of drill down and see what your community is like. When I first went into, so I was a pharmacist first and worked in oncology in a cancer center. And then when I trained as a PA and took my first job in rural family medicine, that was around kind of Myrtle Beach, if you're familiar with South Carolina. So at that point, I got my license and I went to work, and the second week of my working in these rural family health centers, a group of pain physicians, about 7 of them, had been arrested for inappropriate prescribing. 2 of them flew the country, but got extradited. But the way that it worked there is these providers would bring in somewhere between 300 and 400 patients into like a former grocery store. So it was sort of a wide open. There was sort of an elevated stage, and one of the nurses that was with them or one of the physicians would sort of ask broad questions to the entire group. And I guess that was supposed to be the history and physical taking. And then as they left, they would all get prescriptions, usually for 3 drugs: an opioid, a benzodiazepine, and a muscle relaxant. And sometimes as many as 200 or 300 of the OxyContin at a time. So all of those individuals were sort of brought in by law enforcement. And then imagine you're in new practice. So for any of the rest of us in family practice, all of those patients that were now physically dependent on opioids and benzodiazepines and others sort of flooded into the other primary care practices. That was a learning curve. I learned a lot about opioids and Soma and carisoprodol and benzodiazepines of that period. But it's a heartbreaking sort of scenario when you see something pervasive like that. So one of the things to also mention to kind of build our context before we jump into the sort of liability and indemnity point of view is remember that when your state licensing board is monitoring your prescribing, or maybe you're in a pharmacy practice and you're a part of reporting concerning behaviors, they're going to convert everything into a morphine equivalent. So whatever medication has been prescribed, they're going to translate it to this, and then in their algorithm in the state monitoring system, it's going to look at a morphine equivalent dose. And it happens in very different, and I included tramadol because in some states tramadol is regulated and some it's not. But
right, guys,
I've always thought about tramadol as just an opioid, just a little less. Y'all feel like that same way, Chris? Okay, so so what they'll do then is the state figures out what do we want to say, what do we want the algorithm to do to generate an alert that allows us to then open an investigation. An investigation doesn't have to be a bad thing. An investigation could be them sending you a letter or calling you and asking you some questions, and that's it. An investigation could come from the algorithm within the drug monitoring program. It could come from a complaint. It could come from a colleague that you made mad and they want to try to hurt you, and so they may call. I mean, it can come from all kinds of things. I've heard complaints from ex-spouses. I've heard complaints from people that got fired from a job and they want to try to do it, you know. And so boards are pretty good about weeding out the unsubstantiated claims. But the most common reason that investigations occur is because something in this algorithm has alerted you or singled you out, and your practices need to be looked at. So one of the things that we used to do in North Carolina, again, it differs by state, is when individuals had a very high morphine equivalent dose, the amount of opioid you were prescribing to an individual was very high, then you would be put in the top bracket of that algorithm. And if you were lucky, or maybe in the top 5%, whatever volume the board could handle, then an investigation would be open and they would sort of evaluate your practice. You might also be looked at because you had 2 or more patients under your care who died from an opioid-related or drug overdose-related death. That might be another factor. You might also be alerted if your prescriptions included both the benzodiazepine or another respiratory depressant along with the opioid. So it could be a combination of drugs. It could be the volume of your prescribing. Like in our state, we would also look at the top 1% of opioid prescribers as another group to proactively look at. And it differs by state, but in North Carolina at least, they didn't distinguish people that were primary care versus pain specialists or oncologists. Everybody was grouped together. In some states, they may take the pain specialist or oncologist and sort of separate them out and look at the rest of the crowd as their own group. So you just have to sort of talk to your board colleagues or your representative from your region, and if you want to know more, and sort of ask them about that. But the typical things is they look at how much opioid you prescribe in terms of dose per patient, or they look at lethal combinations or potentially lethal combinations, and they look if you're a top prescriber, if you're writing quite a number of prescriptions compared to your peers. Other folks have other experiences from their states? Is that pretty consistent? Or do you not know? I mean, it's happening behind it now. So it used to be that, you know, it was very taboo to gather information about the patients that we cared for because it was considered sort of privilege. That all went away when the federal government began to drive more regulation on our practice to try to stem the opioid pandemic, epidemic, whatever we're going to call it. Catastrophe might be a good word. All right. So they still have to have a court order to investigate you, but I don't know a judge in the last 20 years that if there's a algorithm finding that shows you're a high-risk prescriber, a judge is generally going to allow them to do that. So that's kind of how that works. So greater concern, media, you know, issues came up. One of my favorite things about living in Washington is, do y'all know who during the Trump administration, I'm not going to talk politics, but during the Trump administration, who the opioid czar for the United States was? A little bit of trivia. Do y'all know that? Lance, who was the opioid czar in the Trump administration? It wasn't Hunter Biden. I love a little humor, though. It was Kellyanne Conway. Y'all remember her? Kellyanne Conway she was like kind of on the news all the time. Her husband and she were in different political camps. So anyway, she's like a marketing person, but under the Biden administration, there's actually a seasoned clinician, and actually one of my longstanding colleagues ran that office for a while. But we're kind of back on track with having. I just thought that was fantastic that the cheerleader was the opioid czar. But at this point, both the White House, Task Force on Drug Control, the Federation of State Medical Boards, the CDC, and the World Health Organization have been working very closely to try to put together population-level interventions to reduce death from opioids. So that's kind of where we are. And then as medical boards, as nursing boards, as pharmacy boards, we've had to step up to try to self-regulate, number one, because it's the right thing to do and we want to support our colleagues, but also because we feel like it's necessary lest they create more laws to tell us how we can practice. And I will say from the medical board, I served on medical boards for about 10 years. I'm not doing it now, but when in those years, I will say that there are a few bad apples that are doing egregious prescribing, but the vast majority of people we saw just had over time, with an intent to do good and care for their patients, got into some trouble. It was not an intentional act. And so I think, at least in the 2 medical boards that I've served on, it was a real effort by the board to support prescribers who were in trouble to remediate and get additional training and support. And some we would see had their own issues with addiction. And so there's generally a sense of care with those interactions to try to help people get back on their feet and back into practice. At least that was what I saw for 10 years. But we've had new things come up. You know, prescription drug monitoring is now available in really every state in the US. It differs a little bit about what's there, So in your state, you may be asked to look at the prescription drug monitoring database each time you prescribe, or maybe the first time, or when you're authorizing a refill. In the state where I practice, it's every time an opioid is either filled or refilled, but you'd have to, that would vary state by state. Pharmacists use that information, have used that information to help look for diversion, and which is, I think, a really helpful tool. And so we've had much better understanding of the patterns of use through prescription drug monitoring. There's still a legal diversion, but at least it helps us to capture and be aware of the prescribing related issues with opioids. So and different groups oversee the prescription drug monitoring. Sometimes it's the medical board, sometimes it's the state Bureau of Health, sometimes it's the pharmacy group, or maybe in some states there's even like a consumer protection agency that oversees it, and it's various levels. But regardless if the patient uses insurance or not, those are evaluated. All right, let me sort of roll through these. So here's a few tips I have about how to stay out of trouble if you're using opioids in an appropriate way. The first one is to make sure you document comprehensively and appropriately a thorough new patient evaluation. Even if it's someone who has an established diagnosis that you're taking on, make sure that you either summarize or document using objective data that you've done a thorough new patient evaluation. And what medical boards really like to see is they like to see that you have generated a differential diagnosis, and they'd like to see what you've thought about in terms of what you're ruling out. I don't always do that in a good job. I've noticed when I charted, I do more of documenting my differential diagnosis now in my patient records. I used to just, so it was in my head, it was part of my working process. And but having been through so many hearings now, sitting on panels, I do it more. So if that's a practice that you're already doing, and if you have the ability just to document it, it really will insulate you if they see that you're not just going from, okay, it's a pain syndrome, go to opioid, but that you're considering other options. So think about documenting your differential if you can. And they also want to know that there's some type of meaningful treatment plan. That seems like a ridiculous recommendation, but meaningful treatment plan would be, what is the goal of the opioid therapy or the other interventions? It shouldn't really be people go from a 8 on a pain scale to a 0, right? The elimination of pain in a chronic pain patient is an unrealistic therapeutic outcome. But let's say the meaningful plan that you have is you've set some functional goals with the patient. Maybe it's their endurance at work, or their ability to do activities of daily living, or maybe it's spending time with family, or or maybe increasing their ambulation or their exercise capacity. Think of something that is measurable and functional. Maybe it's mood or general disposition, but you can and you can do it in different ways. But they'd like to see that the outcomes that you're trying to work towards are measurable objective outcomes, not just a pain number or a pain scale. There are tools that you can do for that. I have several embedded in the EPIC panel that I use, but there are lots of functional assessment scales that help you generate goals and then measure, and some really quick ones. There's a nice set of scales that just has 5 domains that looks at different classifications of activities that you live in, and it's a little quick checklist, or you can do them yourself. But I mean, I have one patient I can think about now. I mean, part of our goal was she couldn't really lift her grandkids without a lot of pain. And she just wanted to be able, when she saw her 2 grandsons, to be able to sort of play with them and all that. So that was one of our functional goals that we worked on. And we used a combination of pain therapy and strengthening exercises and stretching and things like that. And, when she was able to do that, she was thrilled. But was her pain score a 0? No, because that wasn't really what one of our goals were. So documenting a meaningful treatment plan. They also like to see that there's a periodic review of their status and if they're making progress towards their goals. And if they aren't making progress towards those goals, have you changed the therapy, or have you just continued the opioid? And I think one of the things that gets people in trouble is when you have kind of a plan, like, okay, we're going to do some urine drug screening, and if you have adverse findings, there'll be consequences, or we're going to work towards these goals. And then you look in the chart a year later or 2 years later, and they've had, adverse results on a urine drug screen, and the opioid is still being prescribed, or there's not really any meaningful documentation of progress towards those goals, but you still see the same opioid prescription. So it's like you got to do something about. Don't just create a plan or have a pain contract, but live it. Operate on it. So I think that's part of what they look for. And if you do get investigated and they actually want to come to your practice site to evaluate your prescribing, they'll do what they call a standard of care evaluation. This is what boards do. So y'all talk to me. Do y'all know what standard of care means from a regulatory perspective? What do you think? What does standard care feel? What do you think it means? Because it's important, because if you're evaluated for anything, opioids or other, anything, the way that medical boards or licensing boards will typically determine whether you're going to have sanctions or not is they will evaluate whether you're practicing to a standard of care. That is the threshold that licensing boards, regulatory boards use, whether it's diabetes or opioids or other. It's not a guideline. They're not checkboxing to see whether you did everything in the CDC guidelines. So the idea is, are you consistent with others? It is a feature of that. So I'll give you an example. So let's say, well, I'll put me in the bad seat. Let's say that I'm being investigated because of whatever reason. Maybe I had 2 patients that died from an overdose, or my morphine equivalents were greater than 90 MMEs or whatever. And let's say that the 3 of us, the 3 of you and I, we all practice in the same discipline. We're in the same sort of geography, and you 3 are all in good standing with the board, the regulatory board. I'd be supervised by the Board of Medicine. So what then the board would do is they would gather some information. One of the investigators for the board may begin to look at some of your records or try to pull together information, but then they're going to call you all and ask you to perform a peer review. And so let's say they randomly pull 10 or 15 charts, and then you all, who are deemed respectable, good standing clinicians in the same field, will evaluate those charts and to determine if my documentation and my decision making and the way that I care for those patients is consistent with the standard of practice that you all apply in your own practice. So they're never going to use a single person. They usually use between 2 and 4, but then applying your good practices, you then would give feedback about what was concerning to you or what was not, or you might even just give a summary recommendation to say, I see no concerns and no significant deviations from standard care. Or you may say something like, in 4 of the cases, there was no this. And so the standard of care is not in a book anywhere. It's determined at a given moment by a group of peers in good standing based on their review of my or your sort of prescribing or care for a patient. Does that make a little bit of sense? So knowing that, then what can we do to help insulate ourselves so that if we do get evaluated by peers, we're in better shape than not? So if you're doing something that's a little outside of the box, making sure that you explain why and create a rationale. That's a fantastic way to insight, because sometimes we need to do that, right? Cookie cutter medicine has never worked. I mean, we have to individualize care. We can apply evidence, but it has to be individualized. So if you're doing something a little different, explain it, or document your care sufficient enough that somebody who's not you can understand the rationale and the reason you did it. That's a great thought. What else? What do you think? So you can make sure that the patient understood the risk and benefits of that treatment, and if possible, shares in the decision making. That's a fantastic idea. What else? Fantastic idea. So I would say that at least 60% of the cases that I've sat on panels before, the prescriber is in, I'm going to use that term because it's different people, are in a solo practice, or they are isolated, or they're not engaging with others, and they just get in this own little sphere, and they're not having feedback, and they're not having conversations with colleagues about what's going on, and they've just sort of moved in that way. And remember, when we're right out of school and residency or our training, that's sort of the peak of our, sort of conceptual knowledge, fundamental knowledge, and it just wanes as we continue to practice. We gain experience, but we don't always gain understanding of peers. So go to local meetings, be in groups like this, sit down with colleagues, whether they're in your practice or in your same pharmacy structure, or maybe it's a lunch group you can get with once in a while, and talk to your colleagues about what's going on and see what their practices are and share what you're doing. And that helps to insulate you and understand what the current standard of care is, standard of practice is. Fantastic. You can also read and study and and things like that, and read new reports. But I think it's really important regionally to sort of talk with your colleagues, because we can learn a lot from each other. So those are some great suggestions. State boards will not expect, they do expect us to help to avoid diversion. They expect us to be a part of that, kind of like when they legislate that we have to look at the prescription drug monitoring, but they're not going to expect us to do pill counts or have pain contracts or do control like urine drug screening or things like that. You can do it. I use a variety of those, but they don't expect that. They just want us to have a plan that we're doing our part to avoid diversion. So I think whatever you choose to incorporate into your practice, just make sure it's something that you can execute and deliver on. But if you're going to put pain contracts in place, but you're not going to hold up the standards that are in the pain contract, you're better off not to have a pain contract if you get investigated. If you're going to use urine drug screens, make sure when an adverse result comes back that you do something about it. It doesn't have to be that you stop prescribing the opioid. Maybe there's counseling, or maybe there's treatment, or maybe there's some type of other intervention, but there needs to be something that happens as a result of it. Sort of make sense? So you decide what you want to use, but just realize in an investigation or a peer review panel, people are going to evaluate whether you live to the rules and principles that you set with the patient. I like pain contracts because I don't prescribe a lot of opioids anymore, but when I do it for people that are warranted, I do set the rules out up front, and I think it's very helpful for all of us. And I say there are things you got to do, and there are things I got to do, and we talk about the pros and cons. And I talk to them about, if enough people use opioids, we're gonna see addiction develop. That's a real risk of using this medication. So we gotta talk about what that looks like and the pros and cons. But I like the contracts up front. And I've been burned a few times by patients that were diverting medications I prescribed. We all will be in time. But if you have systems to identify most of them, then that's probably the best that any of us can do. And state boards are going to look for, what did you do in the face of evidence? What did you do when that prescription drug monitoring system showed you that somebody was getting medications from another prescriber? What do you do when there's no opioid on the urine drug screen, and yet you're prescribing someone regular opioid prescription? What is the treatment that you provide? And just remember, complaints come from everybody. So this is my general rule about avoiding lawsuits and complaints is be kind. If you can generally be kind, it will help you not be complained. I can't tell you how many complaints come from people that were like, in some cases the prescriber was actually doing something inappropriate, but the complaint just came because they made somebody mad or were rude to somebody or something like that. So kindness will also help if the goal is to avoid investigation. All right, so let's look a little bit about the best practice from the CDC, and then I'll show you some cases from the board. Questions about the first part, though, before I keep rolling on. Are you with me? Have you picked up any new things that you're maybe going to consider doing in prescribing opioids, or do you feel like you're doing those things and you're feeling validated? You can see opioid use disorders after as few as 3 to 5 days of opioids. So it's not just a chronic, months or years of treatment. Even if you're in an acute care setting, urgent care, emergency medicine, even short-term exposure to opioid based on people's genetic predisposition can lead to symptoms and increase their dopaminergic need to have more opioids. So just be mindful that it doesn't have to be long-term use. It can be short-term use. So you want to make sure that when you do prescribe the opioid, you've exhausted non-opioid options and it's appropriate. And there are going to be lots of cases where it is appropriate. Okay, so in the CDC's working guidance, they brought together physicians and PAs and pharmacists and advanced practice registered nurses, social workers, quite a lot. And they looked at a huge body of literature that involved individuals that were adults, 18 years or older, who had a pain syndrome of at least 3 months, which is by drug company standards, chronic pain. That's a whole nother issue. And they primarily looked at outpatient settings, and they did not include people that were on, interventional pain treatments that had a cancer-related pain diagnosis or that were under palliative care. So they looked at a sort of a traditional outpatient, non-malignant pain population, not end of life. And that literature was evaluated. They looked primarily at randomized controlled trials. They did look at some observational studies, but they focused primarily on randomized controlled trials, and they evaluated the evidence and summarized the findings for this entire sort of body of literature over this last sort of 10 to 20 years. And there are 2 sets of recommendations that this peer panel came up with. Category A means it's things that we should do for everybody that we take care of on an opioid. And category B means it's some advice we want to give you, but it's really up to you whether or not you want to incorporate or not. And all except one of their recommendations are category A. So they looked at effectiveness, comparative effectiveness. They looked at harm and risk. They looked at ways to mitigate risk. They also looked at how useful the treatments were on the long term. And then they summarized it. And sort of the key, I'll give you the key takeaways first. They found that there were really no long-term outcomes in pain trials. So the majority of the studies that we base our use of chronic opioids on lasted about 6 weeks or less. So there are no really long-term control studies of opioids. So we really don't have any empiric evidence about what happens when you use it for greater than a month and a half. So that was the first thing, which is a huge gap. Opioid dependence was found to vary between 3 and 26% in the primary care setting. They also found that dose-related harm, which we talked about. And the most sort of striking thing for me is that they found that initiating treatment with a long-acting or extended release was not only less effective, certainly not superior to acute release, but it increased the risk of overdose. So it sort of undid that construct that extended release products with a rescue med were the right way to treat chronic non-malignant pain. The evidence does not support that. And I think the makers of OxyContin are still trying to put as much money in secret Swiss accounts as possible as they get lawsuits from every state in the United States. Methadone was associated with higher mortality, and there were very few studies that showed any benefit beyond moderate dose. So at about 50 morphine milliequivalents or less, there was really no empiric evidence to say that pushing that higher created incremental improvement in function for patients. So the guidance recommended kind of staying at a lower MME level. I actually don't prescribe more than 50 morphine equivalents of any opioid because you also see a significantly lower risk of overdose death with that. I will refer to a pain specialist if I can't maintain control at that level. Okay. Keep rolling on here. Sorry, going the wrong way. And then their kind of contextual take-home messages was primary care prescribers are underutilizing non-pharmacologic therapies, things like cognitive behavioral therapy, interventional treatments, exercise-based programs, and so forth. There are also a number of non-opioid drugs that were underutilized as adjunctive agents. They verified also that this idea that the more you prescribe, the more likely you'll see deaths was a close factor. And one of the things that was really striking is that they found that a lot of primary care prescribers were not well versed on how to recognize early signs of addiction behavior, or that they knew what to do when addiction occurred in their patients. And so that was another area where we can make some benefit. And this is why SAMHSA gave us some support for my research team to develop training to help primary care providers recognize and intervene. Because if you treat people with opioids, you will eventually see people that develop opioid use disorders. It's not avoidable if you treat any significant number of individuals. There's a question over here. Maybe? No? Okay. You're stretching. That's allowed. No worries. it keeps hurting you, let me know and we'll get some opioid for that shoulder. Kidding. Bad joke. So the 12 recommendations from the CDC came in 3 categories: when to start it or continue it. So I thought about that a lot when those folks in Myrtle Beach were coming to me and wanted 270 OxyContin and Soma and like 300 alprazolam or Xanax for 4 times a day dose. And I had to like think about, oh my gosh, if I stop the benzodiazepine, will they die? If I stop the opioid, they'll probably feel bad but live. I mean, all of those kinds of processes in your mind. And then the second set of recommendations follow on which opioid, how do you dose it, how do you follow up? And then the last one is really looking at how do you identify risk or harm. So this is the first group, kind of deciding when to start or continue. And they're pretty straightforward. I mean, I will kind of highlight them, but you can sort of read them here. The first one is maximizing non-drug interventions. And to give it a good go, give it a good, meaningful go, not a superficial go. You can document that you exhausted those therapies, or in many cases, even if the opioid has to be used, you may be able to use it in lower doses or periodic or episodic use rather than regular use. The other is that before you start an opioid, you should set treatment goals, and they encourage functional and realistic goals. The elimination of pain is not a realistic therapeutic goal for a person with chronic pain. That's not something that we can safely achieve or consistently achieve. And then related to that, if there's not meaningful improvement in those functional goals, we should think about discontinuing the opioid and try something else. And then the last one is before you start and periodically during the course of your opioid treatment, you should make sure patients understand the risk and the realistic benefits that are going to come from that drug and remind them and reiterate that sort of over and over. People, we have this ability to tune out the bad things and focus on the good things. I think it's part of survival. And if you think about like a pharmaceutical ad on TV, you see, the people with their feet out of the bathtub because they don't have erectile dysfunction anymore, or you see the medicine for the anemia now making granddad or grandma be able to throw the grandkid up in the air, and there's all this fun stuff. And then the last, 3 seconds is, and can also make a third ear grow on your forehead or your liver dissolve. I mean, it's like this, all of this happy, and then a little bit of the safety at the end. And we have to sort of counteract that to be explicit and clear about what the potential risks are. Are you with me? Okay. The second one, which is sort of how, is sort of 4 categories. One is we should use immediate release, not extended release. We should use the lowest effective dose, and I would recommend keeping it at 50 MMEs or less, because if you hit 90 or 100, you're very likely to be in the algorithm for your state medical board to be investigated. And then the question is how many of your peers are in that bucket, and how many of them can they get down the list before the next month's report comes? So I would keep it at 50 or less if you can. If you're a pain specialist and this is what you do for a living, you know it better than me. But for those of us in primary care, acute care, I'd keep it lower. This one focuses on even that short-term exposure can lead to chronic use. And then the other is that we should really continue to monitor harms on a regular basis. And we should try to taper opioids or lower the dosage at iterations. Keep trying to reduce or reduce the load of opioids. And as people get older, they often need less. So for the last one, it's sort of like about harm. Kind of go through these again. I won't sort of read them to you, but the prescription drug monitoring is a tool that you may actually be legislated to do, but you can use it more often than you're required if it's available to you. If you're going to use drug testing, this is the one that's the category B. It's certainly possible to do that. I use urine drug screens as part of my practice, but you can do them randomly. You can do them when you have concern, but just make sure that you act on it if there's a adverse finding. And then I would recommend avoiding concomitant benzodiazepines with opioids. I do see it still done in the states where I've practiced. If it happened, you would automatically go onto a list to be investigated. And this is just, I would still say 2/3 of the deaths that I see, I serve on a safety council for our health system. 2/3 of the cases, there's a concomitant barbiturate or benzodiazepine with the opioid, or somebody's abusing something like kava kava or other things that have similar effects, and that respiratory depression has occurred. So, and then the other thing that like we can do, and we'll talk about in just a little bit, is know how to recognize and screen and refer people for care for addiction when it develops, and be prepared to routinely screen people for substance use disorder symptoms and signs, because it's a eventuality if you prescribe enough opioids. Questions about those? Pretty practical, but they're good. They're good to revisit. Certainly very helpful. All right, so one of the things that I used to run into a lot of change with is, let's say you have a patient that you don't want to continue to prescribe the opioid to again. Do you taper it? Do you cut them cold turkey? What do you sort of do? And you know what we know, unlike benzodiazepines, where there can be life-threatening withdrawal symptoms, opioid withdrawal is probably just going to make people feel pretty crappy, but they're going to get through it. So we don't want them to feel crappy. We want to provide you know, a manageable approach, but the stakes are a little bit lower for us than like a drug like a benzodiazepine. But I like the Department of Health and Human Services guide. They developed a guide on how to discontinue long-term opioids, and I use it all the time. I probably stop more opioids than I start based on the kind of practice I'm in. But I really, really like this guide. It's a fantastic tool. It talks about the different strategies. It talks to you about specifically dosing and how you can and sort of follow that. It talks to you about how to support the patient during the withdrawal process. And it's a really great tool. And it's available online. It doesn't, you can just download it for free. But I like that tapering guide. And then there's a couple other tools that I sort of shared in your slides, but I wanted to maybe run through a couple cases with you. You up for that? Yeah? Okay. Unless anybody's been investigated and wants to share. Kidding. So one of the things that you can do is not treat yourself or your family. That's a good one, right? I've probably in the last 10 years seen 30 cases of people self-prescribing or giving like a child or a spouse a prescription for a controlled substance. And I keep thinking to myself, how do you do that? But it happens, and people do it. But that's a hard to get out of jail card if you're in front of a panel and you've been prescribing an opioid to a loved one or to yourself. That's a really difficult one. And sometimes the prescribers think, well, you know, I used to get it and my prescriber retired, and so I just started doing it, and I didn't think it would be a big deal. My advice would be, don't do it. That would be the first one, simple one. Let me give you a few others. So some of these are going to be more physicians, and I'm not picking on physicians, but working on a medical board, that's the majority of the cases I've seen. So just know that they all of our different disciplines are regulated. But when this physician's regular doctor left practice, he began to self-prescribe for the same controlled substance, or she did, sorry, that her physician had prescribed to her. This was kind of like building on the first slide here. And the other thing that this physician did is she was prescribing controlled substances to close family members that lived in the same household. And so to kind of give you also a little spectrum is, you might say, well, I bet they took her license away, right? Well, no, they didn't. The medical boards are notoriously supportive of our population. So it was a reprimand, a public reprimand, and it was a requirement for that physician to go through training and continuing professional development in self-care and opioid prescribing and monitoring and so forth. And that lasted, it was a formal program that she was asked to go through. It lasted about, I think, 8 to 12 weeks. And then she was able to, she was authorized again to prescribe those drugs again after she had completed and showed remorse for the activity. So, you know, there was about a 6-month period of disruption to her practice, and then she was back in that care. She was also voluntarily admitted to a counseling and care program for individuals with substance use concerns for clinicians. And so that also helped her have a less rigorous outcome, because she voluntarily said, if you can provide me some help, I would appreciate that. So that was sort of the outcome. A reprimand does a couple things though. It's public, so patients can see it or the community can see it, The other thing is that our insurance providers and our malpractice insurance providers can see it. So one of the things that could have happened with her, fortunately, she was not in like obstetrics or gynecology, but it could also make it more difficult for her to be privileged or credentialed or have affordable access to malpractice insurance. So there are some bigger consequences of a reprimand. But she didn't lose her license. She was able to keep practicing. But again, don't prescribe for yourself or family members. Even Zithromax, it's probably a virus anyway. So in example number 3, this was a physician who inappropriately prescribed controlled substances to a patient who had a current mental illness and also who had a prior history of opioid abuse. So that physician prescribed. This was a really tough case. This hearing and set of investigations lasted for close to 6 or 7 months. I remember this one vividly, but the patients had been treated for breast cancer, and the oncologist had sort of cured the breast cancer and had basically stopped prescribing any opioids and said to the patients, you don't need opioids anymore. I'm not going to continue to do it. But she went to the primary care provider, made kind of a compelling case, and despite the fact that the primary care provider was aware that the oncologist wouldn't continue to prescribe it, it was prescribed. There were 60 tablets of morphine that were given, and it was written for BID dosing. But the patient was found a little more than a week later unresponsive in the home and had taken a significant number of those sort of pills. So again, a bad outcome for the patient. That patient actually died from the opioid overdose and had an unrecognized, untreated opioid use disorder. So the medical license for the primary care provider was suspended. An attorney that was representing that prescriber had it immediately stayed. And then that physician had to go through some structured training. And they actually had a little bit more that they had to do. So at this point, they had to review every single patient and document that they had screened the drug, the controlled substance monitoring system. And this prescriber had to not only go through the training, but then went through, like, if you remember from school, like OSCEs, where a panel evaluated them in simulated cases to determine that they had the competency. So again, an educational outcome. And then they had surveillance for about a year where the prescriber's charts were randomly looked at for about a year by a panel. But again, was able to stay in practice even after a pretty bad outcome. Another example was this was an osteopathic physician that had a pain contract with a patient, and he was prescribing pretty large quantities of opioids. And the patient had been told in the pain contract during the visit that if you have a drug screen and things don't come back right, I'm gonna stop prescribing. So this patient had failed more than 4 drug screens, and actually one of them revealed multiple agents that were not prescribed by the osteopathic physician. Yet, when the standard of care practice was put in place, they continued to prescribe, and they had authorized as many as 750 oxycodone tablets in a 30-day period. And just imagine you've got 13 of your closest friends on the medical board in the U-State hearing, and you're sitting in the middle of it with your attorney, your advocate, this setup, and trying to tell this story and make somebody understand why it was okay. This is not a place you want to be, right? For sure. So after several months of the failed test, the osteopathic decided he would stop prescribing. So at that point, they gave 24 oxycodone and 120 methadone. And like at this point, and I remember the physician sort of sharing with it. And I mean, he again was like, he was wrapped up in this dynamic with the patient. And then at some point, he realized, I can't keep doing this. This is no longer helpful. And he was trying to sort of wean the patient off and do it. The patient actually died 2 months later, though, from methadone toxicity. So that's what escalated the case to an investigation and sort of brought him in. His license was indefinitely suspended. He was allowed to come back in 1 year later, but I can tell you it would be very, very difficult with this situation for him to get malpractice insurance in that state. So it would have been pretty tough. If you're an obstetrician or a gynecologist and you're in this scenario, you may as well sell your house if you're going to buy malpractice insurance if you have that type of history. Which one? So a couple things happen. Number one, I mean, again, there is no like 1, 2, 3, you're out. This is a panel of 4 colleagues go in and evaluate his care, and they determine at that point a standard of care and how it was either consistent or deviating with. And they then come in, and that panel provides a summary recommendation to the Board of Medicine. And then the prescriber here, the physician, has the ability also to come in and present his case. And then this panel of 13 sort of peer evaluators determines what the outcome is going to be. So it's a hearing, like a trial, and you know, and oh, it's the same person. And so when the whole story is that he continued to prescribe despite the patient having other things, and then so months go by, and at this point he's like, I can't do this anymore, and he's trying. Does that make sense? Yeah. So it was kind of a sort of a long period. But methadone, is a particularly toxic agent when it's used in overdose, unfortunately. So that was a pretty tough case. This is another example of the osteopathic physician had 3 partners in his practice. All of them had retired. He was the sole one left, and he was by himself in a relatively rural practice, not talking to anybody, practicing in isolation, and that is a real setup for a disaster. Don't do this alone. We're a team sport in healthcare. So he did. He was authorized to prescribe methadone. Yeah. He had a small, it was a very, very rural community, and he had quite a number of people on medication assisted therapy in his practice. He was using much more methadone than he was buprenorphine, which again suggests he wasn't consistent with current day practice and modern treatment of opioid use disorders. Another sort of factor that came to bear. So another one here, this was an advanced practitioner along with an attending physician in an internal medicine practice, and they had adopted an opioid prescribing policy that required regular urine drug screens in their patients that were on chronic opioids. So they were informed that on an ad hoc basis that the patients would have to have a urine drug screen. So they had a patient, she was on long-term opioid, and she called to get a refill of her medication, and she was informed, her name came up, that she'd need to do a urine drug screen to get the refill by the nurse practitioner that was taking care of her. Okay, so this older, not older, but mid 50s, maybe early 60s patient didn't drive, and she was dependent on her husband, who was working full time, and she got really upset and didn't want to have the urine drug screen, and she just needed her refill, and she was concerned that she was going to run out before she could get her UDS. And the practice said, this is our policy. Try to be flexible with you. You can have it done at another practice, but you need to have your urine drug screen. She was very angry. Left about 6 nasty voicemails on the investigators line for the medical board, and criticized both the physician and the nurse practitioner. So this complaint was triaged by the medical director at the board, and they gave her a call back and said, thank you for your feedback. It sounds like you need to have your urine drug screen before you get your opioid refilled, and have a nice day. And nothing was sort of done. So a good example of, we do have colleagues in our regulatory boards that are going to be holding up sort of good practice. Yeah. Hey, we got Uber. So I think what I probably would have done, like if I'm in her situation, I would have gone and get my COVID booster, because that way they'll pay for your Uber ride, and then you can get your urine drug screen at the time. I'm with you. I worked in my father's pharmacy since I was probably about 10 or 12. And boy, you talk about learning some stuff, right? That was some good real world training. So let me sort of stop there. I hope these cases give you a little bit of flavor into what's there. The regulatory boards are not out to get us, but they do have a job to do. And I think the things that we can think about are, opioids are appropriate in a subset of the patients that we care for, and we have some responsibilities when we use it to know when to start it and when not, and when to stop it, but also how to be able to mitigate risk and screen for risk, and make sure patients are committed and they understand we've exhausted other options. And I know that this is a drug with some toxicities, with some potential for addiction or harm, and that we're going to work together to try to maximize the benefits. The other thing is think about some of the steps you can take in your documentation and in your care for patients so that if you are the unfortunate recipient of a letter from your regulatory board, that you can feel confident that they're not going to find anything of concern. And also, as I mentioned before, don't deal, whether it's opioids or other sticky issues in your practice, don't deal with it in isolation. Talk to your colleagues about it. I personally don't delegate the authority to telephone or transmit an controlled substance to anybody on my staff. I think that I'm certainly happy for one of our nursing team to help evaluate when a refill is appropriate, but some things I hold closer. So and the pharmacists in my community know that for Reamer, other people don't call in those prescriptions. So think about what you can do in your own practice to insulate you, to protect you, but also sort of do what's right for the patient. So I did put some additional slides that kind of dig through the 12 steps from the CDC, but I think they're fairly straightforward. And then there's some other resources like some one-pagers and tools from the CDC that can help you when you're educating patients or talking about the pros and cons of opioids. And so those are in the slides as well, but I'll stop and we'll take a little break unless folks have questions. Sure. Uh-huh. I mean, yeah. I don't think you're alone in your approach. Sort of for the folks on Zoom, I'll sort of summarize. You basically, you and your partners in your multi-special practice have sort of set a threshold when you're able and willing to take on a patient or not. And sometimes you say no, but realizing that there's some potential that then they'll turn to other places for the opioid or maybe less desirable options like illicit drug. I think it's a reality for all of us. And so as you think about that, I try to be accessible in my own, and because I've thought about it a lot too. I try to be accessible. And the one thing I'm thinking about is, do I have the training and the expertise and the resources and support to provide the extent of care that an individual needs? That's the first thing I try to look at. Do I have the capability to provide the care they need? If I don't, who can I recommend or refer them to that does have that knowledge, expertise, resources? The other thing I'm thinking about also is liability. I'm seeing evidence of significant deviation from what I would call standard of care in the way that you've been treated. And I think it's very appropriate to have the conversation up front and to say, if I take care of you and we develop a relationship together, I want you to know that I have concerns about these medications or this treatment, and these are very unlikely. It's very unlikely that I would continue this treatment in that way because the harm is too high. I'm not prepared to take on that risk. And I took an oath to do no harm, and I see the prescriptions that you're on, and I see the real potential for harm. And if they get upset, let them go. But I think if you put your expectations and sort of your rules of engagement up front with the fact that I'm going to work really hard to help you have a healthier life and overcome these issues, but we're going to operate in that way. And if people aren't okay with it, I really do say let them go. I think the other thing that you can do is just be really knowledgeable and be aware of what the resources are in your specific community for people to get help. I mean, I've done that before where I'm really not able or feeling okay to take, but I will take the time to sit down with somebody and I'll pull out a list because I usually keep a list in my office of places for substance use disorder, of our pain, specialty practices. And I'll say, I'd be happy to put in a referral. But here's a list of their phone numbers and contact. I'd be happy to recommend some other patients that I've spoke with or see if they'd be willing to talk to you about their experience. But you can also give people something other than I can't care for you. right? But a list of options or things to explore. But in Southern California in particular, it's overwhelming. Yep. A lot of states have put more of their mental health money in buildings than they have in programs, which I think is a real fundamental sort of policy problem for sure. I have a number of patients, like in the District of Columbia, that one of the best things I ever did was we had a social worker that worked within that supported the 4 teaching clinics of primary care. And I actually found that turning to social worker and those counselors was really helpful. It's not something I did early in my practice, but not only could they try to get them and let them know about community resources, but in many times they could help them apply for or get access to health insurance, or they could link them up with charitable groups that would provide support for medical care. So think about our social work colleagues as another resource that might could help them find a way forward or kind of individualize a path to care. But ultimately, I think you have to do what you feel able to do and that you feel is safe for your practice. Because I mean, people, even when we try to do good things, sometimes people will come after us. Um, so I'm with you. No judgment here. Hmm. Yeah. Remember, there was a time we thought oleander leaves could cure COVID, but we moved on from that, right? But I'm with you. I think all we can do is practice knowing the current evidence and the experience we have now. And we now know that we shouldn't have made pain the fifth vital sign. That was a huge mistake. And we know that the elimination of pain is an unrealistic therapeutic outcome. So going forward, what can we do? I'm going to try to help you be as functional as you possibly can to live the healthiest life that you're able to do. But the elimination of pain is probably unlikely because it's a physiologic response and your body is telling you that whatever is happening right now, you need to stop doing it, that your body's not able to do that activity. Pain is telling you that we need to think about. We might could rehabilitate, we might could work on other ways to support it, but zero pain is not an outcome we can achieve together. Yeah, there are a lot of factors. I get it. I mean, yep. One of the things we have really trouble with in primary care is so the CDC and SAMHSA made a big move to train a lot of primary care physicians in a call and PAs and nurse practitioners and others to get trained in medication assisted therapy because there's not enough addiction specialists to treat substance use disorder. So we saw kind of an uptake of people getting trained in buprenorphine and MAT. And then if you look at how many of those individuals continue to prescribe MAT after the first year after training, it goes sort of down. So I think you have to decide, are you willing to do that? If you take on MAT, what will that do to your practice? Are you prepared to do that? I mean, I think it's, we want to fill the needs and fill the gap, but you need to be realistic with yourself and your team about what that looks like. What we do in our adult primary care practice, because I'm in an academic medical center, we have McLean Hospital and huge psychiatric program. But what we do in our primary care program is we're trained in MAT, and if one of our patients in our population develops issues with substance use disorder while we're caring for them, we'll offer them a referral to the substance use program, or they can stay in our practice, and a handful of us are trained in MAT, and we can manage their buprenorphine. So I think what we've tried to come is we don't want to become a substance use disorder treatment clinic because as primary care folks, that's not what we're committed to. But if we cause some of that harm or a part of that because of opioid therapy, we will keep them in the practice and care for them if they want it. And we've been trained to do that, or we'll refer them. So I think you have to decide for yourself what's there. But if you prescribe opioids, like I said, we're going to see opioid use disorder manifest. And so are we prepared to sort of screen and work with it? Hopefully maybe we hadn't solved the problem today, but hopefully there's a few things we picked up to help. So why don't we take a little brain break, and then I'm going to try to set up for our next go, and then y'all will probably be done with me in about half an hour, and I'll turn it over to my colleague.